Hi, this is Eric Harrison. Good morning, HCA, FLHCA Weekly Cardiac Conference. Hope everybody's doing well. This is Beaumont, our smart dog, bringing you Smart Dog Productions. I want to talk to you about a very interesting patient who is a 27-year-old married female who referred herself for a second opinion. She had the recent onset of severe shortness of breath, chest pain, pounding sensations in her chest, exertional dyspnea, moderate prolonged activity producing chest pain. She had a hysterectomy for endometriosis a month before. And so we'll see what happened to her. Pooh, can you talk to us?
Yes.
Oh, good.
Morning.
Oh, good. I'm glad you're here.
Thank you.
We're going to talk about this lady who's 27 years old, who self-referred for a second opinion. She was very active before her surgery, never had any problems, nothing ever reported. I don't know if she played sports in school. That would be a good question to ask. She had lower than normal blood pressure and now lower since surgery and since she saw a cardiologist post-op who put her on metoprolol. Let's see what we can find out what's going on. So she went to the hospital. During her hospital visit, I wouldn't call it a visit, hospitalization for a hysterectomy. Not exactly a visit when you get cut on. Patient was sent home with some shortness of breath. She developed worsening symptoms over the next few days and returned to the hospital. I said, she must be in congestive heart failure. Let's give her some Lasix in the ER. Not a very good idea. And so she went, she may have been overhydrated, she may be dehydrated, who knows. And she began experiencing severe chest pain as she was diuresing and became hypotensive. They said, better get a cardiologist. And she got an echocardiogram. She has an EKG here somewhere, and we'll take a look at that. Of course, post-op, you always think of pulmonary emboli. And let's see what happened. Well, we got a transthoracic echo. We don't have it. I don't know what hospital this was done at, but they said there was basilar septal thickness of 2.4 with SAM and SAC. SAC is systolic anterior chordal motion. SAM is systolic anterior motion. Mitral valve. I thought she had a left ventricular obstructive syndrome because of that. And so that's like a subaortic obstruction, but not membranous. It looked like it was clearly the septum, so that would be hypertrophic obstructive cardiomyopathy. No Doppler was done. Can't understand what hospital you wouldn't do a Doppler in, so I don't know what that's all about. Dr. Morale saw this patient. I didn't see her, so I can't tell you what the story was at St. Elsewhere. However, she was put on a beta blocker. Sounds appropriate for somebody that has hypertrophic cardiomyopathy. Maybe not somebody who's hypotensive, however. And so I'm not sure if this is just sort of a routine, let's put her on a beta blocker, or if it's personalized medicine, individualized to this patient who just got Lasix, which probably is not a good idea in somebody with HOCM, to volume deplete them with a diuretic. So that causes greater obstruction. And so that's a challenge. And so now putting her on a beta blocker may not be such a good idea either. So she apparently was advised her cardiologist to continuous medication, and she still was symptomatic, which she never had before. And these were post-op symptoms, I guess. And so she was driven to go to another cardiologist because she wasn't happy with the results. Apparently she was pay-as-you-go, self-pay, uninsured, which makes things even more complicated. And so here she is with newly diagnosed HOCM and hypotension, bad combination, history of endometriosis. Well, that's been solved with hysterectomy, unless she has some ectopic endometriosis. And then a medullary sponge kidney, recent hysterectomy, bilateral tubal ligation. So I think she already had children and had the tubal ligation, and then had to get the hysterectomy and had a cholecystectomy. I don't know if that was a time of hysterectomy. Do you know, Hassan? Or if that was a different opportunity. We don't know about her body habitus, so we'll have to find out more. No ischemic heart disease or pacers or sudden death. So we would think that because of that, she would be a spontaneous mutation rather than having a family lineage of sort of IHSS type family lineage. She works as a server, smokes half a pack a day for 5 years, trying to quit, occasional alcohol use, no excessive caffeine, no illicit drugs, peanut allergy. Not sure how severe that is. That would be important to know about whether it's anaphylaxis or not. And then she's on the metoprolol 25 BID. Don't know what her heart rate is. So let's take a look and see what we can find that's more interesting. Well, here's her heart rate, 55. And her blood pressure 92 over 58, not very good for IHSS. Her BMI is only 21.5, so she's not markedly obese. And looking at her stuff, she does have a systolic murmur, worse with Valsalva. As you know, there are several phases of Valsalva, and you would have to stipulate which phase is it worse. And then she's got 2+ carotids, no comment about whether she has a funny pulse. And so patients that have systolic ejection type murmurs that are very loud like this, you want to feel for their pulses to see, is this aortic stenosis? If the pulse diminished in terms of the pulse pressure when you feel it, even though she does have 92 over 58, if that's diminished, that feels like aortic stenosis. If it's sort of bounding with a nice upstroke, then it feels like hypertrophic cardiomyopathy. Bowel sounds are okay, and distal pulses are okay, and so really nothing on the physical other than this murmur and not much comment about the carotids. Usually you'll hear this murmur radiating up the left sternal border to the jugular notch and into the carotids. Here's an EKG for Pooh to look at. So Pooh, comments about the EKG.
So they're like, I don't see clear P waves, but maybe there or sinus bradyude, there are junctional deep T wave inversion, which is consistent if it's going to be with apical HOCM. If we see Q deep, like Q waves and laterally, that would be more septal, but definitely EKG is suspicious for HOCM.
Yeah, so the any comment about the axis?
Axis is rightward on this, and then LVH is pattern, but that's more consistent with HOCM than true LVH. V1's up, which could be either RVH or V1 usually should be, R wave shouldn't be this much up, more than 7 millimeters, or R more than S and V1 RVH involvement.
Yeah, so right axis deviation is pretty unusual in HOCM, and so that's an interesting finding. And then sometimes you can get right ventricular outflow tract gradient as well, and we measured simultaneous LV-RV, and we've actually done simultaneous injections and been able to show huge septum. Of course, the septum belongs to the left ventricle as well as the right ventricle, and so sometimes you get right ventricular outflow tract obstruction, and you can get, this is very unusual though to see this axis. The tall R wave in V1 is not unusual, but the axis is. So let's see where that leads us. So the patient's echo from the last hospital visit was revealed in detail. Okay, well, don't know why they didn't do, Doppler. And then no immediate risk of sudden death identified. So no current indication for ICD. Well, that means she's had no syncopal episodes. The thickness is less than 30. No family history. personal history arrhythmias. So that sounds like that's a pretty good idea. And then let's do the Zio. That would be a good idea too. But patient is on her own self-pay, so she may not have that. So let's just figure out what's important and see what we can get. And so the suspect was the new hypotension was brought on by adding the beta blocker. And of course, the hypotension then leads to left ventricular outflow tract gradients increasing and greater obstruction. So the idea was to use a new drug for IHSS, for hypertrophic cardiomyopathy, and the new drug being avobradine. That's not been used much. There's not much research showing the use of that. And so it would increase diastole, and that might allow for greater time filling. Greater filling time may be a benefit. So it's not going to affect the blood pressure. It's a funny channel blocker. And so it's just going to slow the SA note. So at least we know it's not going to affect the blood pressure, and it may give her some benefit if it slows the SA note and gives her continued slow heart rate, more diastolic filling time. So that could be helpful in restrictive cardiomyopathy. So consider treadmill stress testing. Well, we do that all the time. We get the resting gradient, and then we get the exercise gradient, and we put them on drugs and check the exercise gradient and see if it's reduced. Drugs usually don't affect the resting gradient. It's usually only the exercise gradient. Patient may have a cardiac MRI to assess the magnitude and distribution of the hypertrophy, as well as the anatomy mitral valve or papillary muscles. Well, I think that's sort of, if she's self-pay, that may be frosting on the cake, and I'm not sure if that's entirely necessary. It depends on what kind of out-of-pocket price you can get for her. She had to spend the money on the hysterectomy, and she must have been budgeted for that, or maybe she seems like she would have met her deductible by now with that, so I don't know what her kind of insurance she has, or if everything's self-pay. But that's certainly is a beautiful test and certainly illustrates the anatomy, but shouldn't be superior to the echo, and really not necessary. But academically, it's a great thing to have, and I love the pictures and the images, and it'll certainly be helpful to us instruction-wise. How about her chest pain? Do we need to rule out coronary anomalies? And could she have some kind of coronary problem? And we can't do the coronaries on the MRI because we don't have a breath navigator yet. And so until we get that, we have to use the CT. CT's radiation. If you were going to look for coronary disease, you would have to reduce the radiation as much as possible in a lady this age. And so you would like to do step and shoot, and you'd like to do only a diastolic image to just keep the radiation down to 3 millisieverts. If you do a complete study, it might go up to 18 millisieverts, which might not be a good idea in this age group with breast tissue exposed. So let's see what happened with this. And so no insurance. You want to hold off on any testing. Discuss further with her husband before going on. So advise to avoid any strenuous activities for now. Report any alarming symptoms. So since we wanted to know more about her, and we just had the one echo, which was not very good, the one EKG, no Zio, a history that sounded pretty good for not being at risk of sudden death. Said keep out of trouble for a while, and we need more information, I guess. Patient was doing well until 2 days prior to she came back over and developed increasing shortness of breath and chest pain. Actually came to Memorial Hospital, I guess to the emergency room, and had her first echo that we've done and another EKG. And then Dr. Morales was consulted, and he was the one that was consulted before as an outpatient. So he got consulted as inpatient. Pooh, you want to take a look at this EKG and compare? I think you can see the P waves a lot better.
Better here, yeah. Pure short. Again, T-wave inversions anterolaterally, but not as prominent, even inferiorly. Q waves are little better defined. But yeah, T-wave is still consistent with hokum. Axis is still rightward, but that RVH pattern is not present anymore. So maybe that was lead misplacement.
Yeah, it looks like there's some difference in lead placement because we don't have the tau R wave over here. So we missed the transition. It went from a big S wave or QS to a tau R wave here. So we didn't get the transition that we got before. So these leads are different from the leads on the previous EKG. And then, of course, the T-wave vector looks about the same. A lot of voltage and more of a QS over here now. So here is an echo for us to look at. And so let's see if this is going to play. And this is not playing. There's a way of solving that. Remember that we had to put one on to get it to play? Hang on, we'll check this out. And so there's a systolic, it looks like some Doppler activity here in the outflow track. And I can't tell about this leaflet. And since it's a non-dynamic, non-action show, and so there is a way to make this play, and we worked on it before, and it has something to do with GoToMeeting and PowerPoint conflicting. But suffices to say there's a gradient in the outflow track, and you don't have this on the other computer, do you? Okay. All right. So we've got the echo showing hyperdynamic systolic function, asymmetrical septal hypertrophy. We get 2.5. We usually measure the ratio of the septum to the posterior wall, and greater than 3 to 1 is considered, greater than 1.3 to 1 is considered abnormal. 1.3 to 1 is considered abnormal. And so severe asymmetrical hypertrophy, dynamic obstruction, and they said it was 55 millimeter gradient in the outflow tract, abnormal left ventricular relaxation, grade 1 diastolic dysfunction, and there's some SAM and some SAC and some mild, moderate mitral regurgitation, all pretty common. Doesn't say anything about the right ventricular outflow tract and whether there's measured any Doppler changes over there. We've seen them simultaneous. Given the right axis, you'd wonder about that. So let's see what else we got here. Right ventricular systolic function was normal. Right-sided gradient question mark. RV systolic pressure, we don't have a measurement on that. The aortic velocity was increased due to, I guess this is due to instead of die, due to, let's change this to due to. Hang on here. We'll erase that and put a U. Due to increased transvalvular flow etiology. Pulmonary arteries obviously were dilated, so I don't know why that is. Why are we getting those right-sided changes on this patient? So there could be a right ventricular obstruction. And so that's my question, because of the right-sided changes, and that causes the pulmonary arteries to dilate because of like post-stenotic dilatation. And so it could cause the IVC to dilate also, so that could be. So questions about a right-sided gradient abound. And so plan CCTA, CMR, overnight on avobradine or heart rates on tele were 35 to 40. Whoops. So I don't know what our heart rates normally are, and so I can't tell you if that's, a lot of people have normal heart rates while they're asleep of 35 to 40 if they're very parasympathetic. So, but the avobradine was stopped, and I'm not sure what the dose was on the avobradine. Maybe 5 twice a day. And so, and here we can't play this either. And so don't worry about that. And we do see marked hypertrophy of the interventricular septum during systole, and this is the inferior wall during systole, and it's just obliterating the calf, the apex of the left ventricle, and the mid part of the left ventricle is totally obliterated during systole. So again, consistent with hypertrophic cardiomyopathy. And now we're going to go look at the CMR and see what these images look like. So hang on here. Okay, so here we go. We've got, first we have a survey, and this is our survey. And you can see there's a lot of hunky muscle here on this survey that we do. Survey is usually not for diagnosis. It's just to find out where the heart is so we can make our plans. But this survey is diagnostic of septal hypertrophy. Remarkable. So the survey, which is not usually thought of as a diagnostic imaging technique, it's just quick and dirty, and there's lots of movement, lots of breathing, no breath hold. We're just trying to position everything so we can position the heart, and you can see this was very abnormal in every way. Here's her kidneys. She's supposed to have medullary kidneys, spongy kidneys, and they do look a little funny down here. So let's go to our next image, and let's see. This is the black blood image, and the black blood image shows septal hypertrophy. That's dramatic. You can see the ratio of the posterior wall. It's like 3 to 1 instead of 1.3 to 1. It's very dramatic. Here's pulmonary artery, supposed to be dilated, aorta, descending aorta, coronary, LAD, right coronary origin. Looks like circumflex over here, main left. There's the main left. Looks like the main left has a normal origin. Right coronary looks like it has a normal origin, as best I can tell here. Looking at pulmonary artery, so we're backing into the right ventricular outflow tract to see if there's something going on here. So I really can't tell. You see the septum is pretty hunky, and so whether that's impinging on the right ventricular outflow tract, I can't tell yet. But we'll look some more. There's the right coronary as it goes down. See it? There it goes. Right coronary. And so getting some good information here. Okay, let's go to next image, and we'll do functional here. Wow. Well, that tells you where we're looking when you see this hypertrophy. This has got to be inferior septal of some sort. And there's the anterior wall, looks good. The apex looks good. It's not an apical hypertrophy. We'll get some more pictures and be able to tell a little bit more here in a minute. I can't see these pictures laid out. Oh, it just goes like that. Okay. So here's another one. Let's see what we can make out on this one. We can scroll beat by beat. So diastole, mitral valve's open. Can't quite see the outflow tract. It's right in here. Looks like some turbulence in there. Yeah. Can't see what's happening in terms of leaflets and SAM, but there is definitely turbulence in the outflow tract of the left ventricle, as we can see it there, like a 5-chamber. So let's go to the next one here. Oh, okay, here's some measurements. These are all measurements. We already had that one. Oh, here's a new picture. Okay, this is our stack of short axes ranging from the apex, and then we're going to start over at the base. So here we are at the base, and we're coming through, getting these images, septum getting bigger and bigger, pretty big septum, even now it goes down the apex and it thins out a little bit. So you see the pulmonary valve. Can't tell you if I see any gradient beneath the pulmonary valve or not. It sort of disappeared there. But we certainly are impressed by that. We've seen this picture, sort of. That's a good picture. We've seen that one sort of too. Here's an image where we can see inflow and outflow And let's do this. See if we can row through systole. There's systole. Let's row through systole again. So this is where that anterior leaflet buckles over. This is where we get high flow and outflow tract obstruction right there. And you can see the high flow represented by the black. Very high flow. So there is the obstruction demonstrated very nicely. And there's a little mitral gurge. See it blowing across here? Yeah. We got gradient here, obstruction, high velocity, some MR, not too much. Left atrium doesn't look big. Obliteration of the left ventricular cavity. Let's get this one going. So this is abnormal. And so what we're interested in, this is supposed to be the right ventricular outflow tract picture. And it's a standard picture. We just rotate everything around. Here's the pulmonary valve. And you see there's compromise of the right ventricular outflow tract. And so that's explaining our right axis deviation. And it looks like this is being squeezed too. And I can't tell if there's a gradient over there. I don't think we did. We didn't design this study specifically for that. It's a routine study for the right ventricular outflow tract, and it shows that the right ventricular outflow tract is obliterated. And then we get down here and we get the right ventricle, and it's just totally obliterated. So that explains the right axis deviation, the tall R wave in V1, and the fact that the PA is dilated, and probably the IVC dilatation are all explained by that. So we've got biventricular outflow tract obstruction. Hang on, let's see what we got here. It's another black blood type study, and there's some artifact from motion. No new information added. And measuring stuff. More measuring stuff. Make this one go. Same thing we saw before, except we're gradually moving up and down. I don't know if this is a special study that we do for the outflow tract of the left ventricle. Maybe a separate sequence to try to dig into that. But it's more the same. Measurements, phase study. Again, compromise of the outflow tract of the right ventricle into the PA again. So biventricular hokum. See what we get here. Not sure what this is for. Got some artifact. Let's make this one go. This would be interesting. Again, trying to open this up, and I think there's some obstruction over there. Here. For these are leg gadolinium enhancement studies that we're looking to see if we've nulled the left ventricle and looking for a scar in the septum. So you can get infarcts and you can get scar in the septum. And so you should see if there is a very, very bright echo, very, very bright gadolinium enhancement. And so I'm not seeing any very, very bright gadolinium enhancement in here. nulling the left ventricle. No, I can't say that there's abounding scar tissue, which is another indication for arrhythmias for macro reentry. You got to make sure that's not present. And so, and we talked about the CMR and the findings, systolic motion, talked about the gradient, and we looked at all these pictures pretty much. Oh, now we got the CT images. So let's get the CT images up. Okay, let's look at the CT. And we're here to make sure there are no coronary anomalies. So if you Google HOCM and coronary anomalies, you will find origin of left ventricle from left coronary from the right. You'll find a bunch of stuff. And so as it has to be, you know, so many people have HOCM and then so many people have coronary anomalies, and so it's going to happen that you're going to have both at some point. And so we can see the coronaries look really nice, and we can see the coronary origins. I'll just take a look at that and show you that, because that's what we're here for. We're not here for coronary artery disease. And so coronary origins looks like it did on the MRI, and looks like it did on the MRI. So coronary origins are normal, all right? And so no problem. We wouldn't expect coronary artery disease or plaques, and so we really don't have to look for those. We do see some little black spots. And so let me show you these little black spots. These are pretty common in the apex. And you see these little things that are little, see these little tiny black spots there. See if I can make them bigger. Well, that's too big. You see these little things here. Those are like little infarctlets that we seem to see on people who come in the ER with chest pain. These right there. The lines don't count. It's these little black things. And so sometimes you see them in the papillary muscles. Sometimes you see them in the septums. A lot of times you see in the apex. And they're little tiny infarctlets that seem to coincide with the troponin elevations that folks have when they keep coming to the ER. And so that's also seen in LVH on occasion, but more commonly seen with HOCM. So let's go back to our other pictures, see what else we can figure out from looking at this. And so hang on just a second, and we'll look at this in more detail, and we'll make this smaller. Let's make it bigger. There we go. Now let's just take a look at this in detail and see what we can make out. And we can actually look at this in several images. Let's go over here and look. So here's where we're concerned about. This is LV, and this is very thick. And you can see the septum belongs to the LV and the RV. And so you can see here, you know, that there's a lot of septum here in the RV. And so I'm wondering if that's not a gradient producing abnormality over there. So here again, big septum over there. This is not dynamic. We can look at it dynamically in a minute, so that would be good. So fortunately or unfortunately, we did do a whole series of all the images. And so with that, I think that was done academically to show, not to show that there's no coronary anomaly, which was the reason for doing the CT, but to academically show the gradient and the dynamics of hypertrophic cardiomyopathy. Unfortunately, this does give you 18 to 22 millisieverts of radiation, and that would have to be balanced against the need to have this information. So let's take a look at the left ventriculogram that this produces. Hang on. So we've got systolic bowling the anterior mitral valve leaflet into the outflow tract, and here's the septum. Not a very good image to show this, but I'm trying to show you the dynamicism of the obstruction. As it moves through systole. So it is dynamic. Let's go to look at some other images of this. We can actually display these all at one time and watch it function and dial in whatever we want to dial in. And we can put the stop on it and move backwards or forwards. Not exactly what I want to do. Hang on here. So we're trying to show if there is a systolic compression of the outflow tract in this image of that septum coming over into the pulmonary outflow tract. You'd have to have a catheter in there, or you'd have to have do the MRI and put a phase in there and look at it. But it does look like something going on there in the outflow tract on the right side. You can watch systole simultaneously across the spectrum of images with coronal, transverse, and axial, sagittal. You get all three. So hang on, we'll go back to tell you some more. So this was certainly showed you what you wanted to find out about the coronaries and gave you a little added information. Not sure if it's worth the trade-off in radiation. Hang on. Okay, and so diastole and systolic frames exhibiting what we thought they would show. No evidence of coronary anomalies, which was the mission. Coronary stenosis or plaque, we didn't figure on that. Severe asymmetrical septal hypertrophy, well, we knew that. Systolic anterior motion, we knew that. Mildly dominant pulmonary artery, that's interesting. And no pulmonary emboli, that was good information to find out, because that was always lurking in the back of your mind with the right axis and the T-wave changes and someone post-op. And so that was important to get to that. Let's go back and check on that again. So we're going to go back to the CT and look for pulmonary emboli and show you how we do that. So let's go over here. Actually, we can go to the gallery and we can pick lung CT. There we go, lung CT. And then we bring this up and then we pick this. And then we come over here and we scroll for pulmonary emboli. So let's get to the pulmonary arteries. And there's the pulmonary arteries, right and left. And here we are scrolling for pulmonary emboli. You got to look very carefully everywhere simultaneously. I just take one side, I take the upper. You're looking for a filling defect. I'd like to see it one of the big ones. And then you come over on the other side. You can't confuse the pulmonary veins with the pulmonary arteries, so you got to keep coming back to the main pulmonary artery branching and follow the vessel out. And look for something that's a filling defect inside these little pulmonary arteries. And I don't see anything. So I'm satisfied. So let's go back to our PowerPoint presentation and say, yep, that's true. So suspect her symptoms are related to hypotension. I believe so. And prior to surgery, she had no symptoms. She goes to surgery frequently. Your NPO after midnight. You don't get much fluid. Surgery may be delayed by somebody else using the room. Finally, you get to surgery and you're dehydrated. And then you have the surgery, and if you have a ventricle that's sort of muscle bound, very thick, and you're hypovolemic, you're going to get more and more outflow tract obstruction. You're going to become hypotensive, and they're going to frequently interrupt surgery. So we see this all the time, and you have to take these patients and take them as first case, and you've got to really hydrate them. And they're not going to develop congestive heart failure from volume overload unless you really, really give them a lot of volume. So you got to keep them well hydrated. And then if their pressure drops, and then you put them on neosynephrine, then you've even got more problem, because that's, again, a contraindicated sort of treatment for HSS and so our HOCM. So we're getting worse, insult to injury. So patient was weaned off metoprolol, feeling better, on ivabradine, then discontinued the ivabradine because of a heart rate of 30s, and these medicines weren't helping her. And then she welcomed good hydration, and currently she's on a monitor, scheduled for a repeat echo off of medications to find out what her resting gradient is, I presume, which they didn't measure the first time off of medications. So patients with hypertrophic cardiomyopathy have an increased risk of death from several causes. Sudden cardiac death is the most common. It's the most common cause of sudden cardiac death in athletes and teenagers in our country. In Italy, it's it has to be right ventricular dysplasia, arrhythmogenic right ventricular dysplasia. In Italy, in us, it's HOCM. Risk stratification to be performed in all patients, regardless of their symptoms or hemodynamic status or morphology. You do some risk of sudden death assessment, and then come to some conclusion. And this is a pyramid that was developed. We're going to let Dr. Hassan Tariq discuss this part. So go ahead, Hassan.
So I found this on UpToDate, and they basically just go over some of the different risk factors for sudden cardiac death. And so for patients who have indications for ICD placement to prevent that. And so for secondary prevention in patients who've had a cardiac arrest or have evidence of sustained ventricular tachycardia, also patients who have a family history of sudden death, or I believe this is hypertrophic cardiomyopathy related to sudden death. Also, if they have unexplained syncope or they have non-sustaining ventricular tachycardia on a Holter monitor, abnormal exercise blood pressure response, where you get them to exercise, and if the blood pressure does not rise more than 20 as you would expect, or it just drops suddenly more than 20 during exercise, that's considered an abnormal blood pressure response, and that's also sort of an indication for an ICD placement. Also, late gadolinium enhancement of greater than equal to 15% of the LV mass, or have a very, very big left ventricle which measures more than 30 millimeters. In our patient, it was 2.5, so it was 25 millimeters. And then you have some of the other indications. Now, hypertrophic cardiomyopathy patients can actually have left ventricle apical aneurysm, so you kind of look for that also. And you also look for how well their ejection fraction is. And some of the other also risk factors are also given here. And so based on these factors, you get an idea of what the indication should be, whether they have a not such a high risk or intermediate risk, or they're higher risk, and then you put them on ICD. And I think this is just giving you some results from 2 different registries where they did put patients on ICD, and they were showing how often they were getting arrhythmias, what the discharge rate was, and how it differed in patients where it was put in for secondary prevention or primary prevention. And yeah, and this here is just looking at some of the treatment for HOCM.
So there was one factor on the risk factors that was basically a negative risk factor, and that's age greater than 60 is a negative risk factor. In other words, that's not a risk for sudden death as you get older with HOCM because you have had a survival test. And so you get to be 60 and 70, you're not going to have sudden death. If you would have had it a long time ago, basically. And alcohol septal ablation, I don't know if that's considered a negative risk factor. Could be. There's a question mark about it. So we don't know. So let's talk about some of the treatments, and there are some novel treatments with new drugs, and you saw for the first time the introduction of ivabradine. You say, oh my gosh, that's not an appropriate drug, but it may be. It's not negative inotrophic, but it certainly is negative chronotrophic and can allow for greater diastolic filling time, which may be very helpful for any restrictive cardiomyopathy. Ranolazine is being tried in a trial, and so we don't have the results of that trial. It's still ongoing, but it'll be interesting. Amiodarone has been used to prevent sudden death in patients. Norpace has a deleterious effect in that it prolongs the QT interval, but it has a very positive effect in reducing ventricular systole and sort of a negative inotrophic effect. And so that's been a great drug for patients with chest pain. We've had good results with that. Calcium channel blockers, everybody sort of winds up on Kalin or verapamil at some point. Beta blockers, mega doses of beta blockers are not uncommon. 200 milligrams BID is a starting dose. And so we'll find out more about this in the future. And there was a little movement to put pacemakers in people to sort of take out the abnormal septum by having the septum not squeeze at the same time the lateral wall did, and hoping that would help. But it doesn't seem like long-term that's been a benefit, so it hasn't lasted. Alcohol ablation is an option, and we'll talk about this in just a minute, as well as a surgical resection. And then you can do genotypic testing. You can test whole families. You can echo whole families. You can test athletes with EKG as a screening test, but it's very difficult because of athletic hearts. And then echo is a screening test, and that's difficult too because it costs a lot of money and takes a lot of time. MRI is a screening test, another way of going. And Dr. Angelini has that for coronary anomalies, and he ran into some cases of idiopathic hypertrophic cardiomyopathy. And so HOCM can be in various levels of maturity at the time when you screen. And so if you screen a whole group of people and they're age 15 and somebody doesn't have HOCM, that doesn't mean that if they have the gene, they're not going to get it. And so they may come back and 3 years later have a significant gradient, and they were told they were okay on the screening, and come back and contest that because they had passed out, syncope, sudden death, whatever, and they were screened and told that they were okay. So that's one of the liabilities of screening, is that they haven't matured to develop the disease yet. And of course the other liability is the overlap of the athletic heart, and so it makes it difficult for screening because of that. Atrial fibrillation can be devastating in somebody who is an elderly patient, an older patient. That puts them in the ICU. You got to get them out of atrial fibrillation. You got to keep them out of atrial fibrillation. So look for atrial fibrillation if the left atrium is getting big and they're having some mitral regurgitation. They may get significant mitral regurgitation. Maybe solving the outflow tract problem will relieve that, or sometimes they have to have a mitral valve. The elderly type of patients seem to tolerate it well. I made a presentation once of 10 consecutive cases of hypertrophic aortic stenosis, subaortic stenosis in a group of patients over the age of 70, and they were doing well. A lot of them had hypertension, but that may be just natural for them, and very few had infarcts or infarctlets. And so this is the idea about what you need to think about. This is really important because these cases are not uncommon. I guess I must have 15 in my practice, and so they're not all that uncommon. But what do you do with them when they are severe and they're not responding to a calcium blocker, beta blocker, they're not responding to Norpace? What are your options? And so these are the two options that everybody talks about, myectomy or ablation. Well, during this period of 2003 to 2011, 57% had myectomy, which is on the decrease nationally, and 43% had ablation, which is on the increase nationally. However, the results were so different. The ones that had a myectomy, there were 6% who had no benefit, and the ablation, there were 25% who had no benefit. And so let's go to a major center. And there's a group of major centers, and these are the 14 major centers in the United States. And if you have somebody who needs surgery or ablation, I would suggest one of the major centers. And so these are they. And so basically, outside of the major centers, 80% of the myectomies are done outside the major centers. And it turns out they have a very high mortality if you're doing less than 20 in 9 years. This is the database. And so that's not a good idea. However, the ablations seem to have a lower mortality, but 25% have no benefit. So that's not a good idea either. So the best idea is to send the patient to one of these centers. And so, and we can see examples of people. Here's somebody going to a non-center, major tertiary referral center for coronary artery disease and had a token myectomy, and faint hearts don't win fair maidens, and so basically just a little tiny piece of muscle was taken out and the patient was no better. And so that wasn't a good surgery. And here's an example of a 34-year-old female who went to a local hospital, what I call village hospitals, and at the local hospital had a robust myectomy, created a VSD, had to get patched, lost the circumflex, had to do bypass to the circumflex, 12 hours on the pump in the OR, and what a catastrophe. And so, you know, if you're a smart surgeon, you don't want to do this. If you're a smart surgeon, you want one of these people to do it because they do it every day and all the time. 250 cases, you know, in a year, that's a pretty good volume. And so the same with ablations. And so it's not amateur hour when you've got these patients. And unfortunately, people are trained, and you think you've been trained to do this, and you may have seen a bunch of them when you're in training at Emory or Houston. And when you get out of your training, you feel you're competent, but you're not competent if you don't do them all the time. So that's pretty much the lesson we have today. Thank you so much for attending. We'll see you later, Pooh. See you, Mary. Thanks so much.
Thank you.
Talk to you later. Bye-bye.
Bye.